All right, our next speaker is Dr. Timothy Wilkin, who is now the Chief of ID and Global Health at University of California, San Diego. He started his career back around the turn of the century in 2000 at Weill Medical Center in New York with Cornell University, working with another one of our speakers, Trip Gillick, who will
Yeah,
be coming
prompt him to
up.
share his slides.
Uh, um, and uh, and Tim, while I'm introducing, if it's okay, just go ahead and share your screen. Great, thank you. And then he's worked a lot on all types of HIV-related issues, especially with the AIDS Clinical Trials Group, has been a leader in that entity for over a decade and a half. And he really has focused on a lot of issues, but one in particular is working on the evaluation, screening, treatment of HPV-related disorders, and was part of the Anchor trial, which he's going to, I'm sure, talk about here. But Tim, it's a great pleasure to have you join us, and we look forward to hearing your talk.
Great. Thanks, Mike, for the nice introduction. Just confirming you can hear me.
Yes, yes.
Okay, great. Here are my financial relationships to disclose. And our learning objectives. So there is a lot that's gone on recently with prevention of HPV cancer. So we're going to help you describe the epidemiology of anal, cervical, and oropharyngeal cancers in people living with HIV, at least understand some potential anal cancer screening strategies for people with HIV, and spend a few moments to talk about HPV vaccination as it relates to prevention of anal and oropharyngeal cancer. So just an HPV primer. So this is the epithelium. On the bottom is the basal cells here that kind of line up. These are the target cells for HPV. HPV transmission happens with breaks, micro breaks in the skin, and the HPV particles bind to these basal cells, and over time they enter the cells and can start the HPV disease process. When we talk about how we interfere with this, first of all, HPV vaccination creates antibodies that bind the virus either before it binds the basal cells or after it's bound the basal cell, but prevents the infection of the target cells. When we talk about people with HIV, the immune system really has a big impact on HPV pathogenesis. So with lower CD4 counts, immune suppression, there's really this process is really driven forward. So ART can interrupt that process by improving immune reconstitution and slowing HPV disease. There are certainly other cofactors such as tobacco that really promote HPV disease. So over time, we try to interact and screen and treat these HPV pre-malignant lesions before they turn into cancer. So a bit more about that. When someone's infected with HPV, it's really just a small minority of infections that really persist over time. And it's this persistence of HPV that when there's enough time and integration of the HPV DNA into the host DNA, there could be the changes that lead to high-grade squamous intraepithelial lesions or a pre-malignant condition, be it in the cervix or the anus. And once those conditions are left untreated over years, they can progress to invasive cancer. So when we talk about the lifetime risk of HPV, basically everyone has some sort of HPV. There's hundreds of different types of HPV that infect all types of skin. For the purposes of what we're talking about today, we're talking about the subset of HPV that is spread through sexual activity that affects the cervix, the vagina, the vulva, penis, anus, and oropharynx. And so most people are exposed to at least one of these types over the lifetime. So men who have sex with men have a much higher prevalence of anal HPV infections and really are the group at highest risk for developing invasive anal cancer. As far as HPV cancer cases in the US, there's about 40,000 per year. It's sort of steady or increasing slightly. But worldwide, cervical cancer is a huge cause of cancer deaths among women, with over 300,000, or in some estimates up to 500,000 deaths per year. And it tends to be the leading cause of cancer deaths in women in low and middle income countries. So 85% of cervical cancers worldwide occur in those low resource settings. As far as US trends of HPV-related cancer, cervical cancer rates continue to decline, and that's because we, for the most part, have effective screening programs, and we've had modest success in rolling out our HPV vaccination. So perhaps there's some effect of vaccinating about 2/3 of young girls, slightly less for young boys, creating some herd immunity that's helping to reduce cancer rates in general. But cervical cancer rates are continuing to decline. It's not really the case with anal cancer. There does seem to be an increase both in men and women for anal cancer. In the general population, it's still a relatively rare cancer, and we'll talk about specific subpopulations or rates of anal cancer in just a minute. But overall, there is a slight increase in anal cancer in the general population. One thing that hasn't, I don't think, really gotten quite enough attention is the rates of oropharyngeal cancer. So now we think of HPV cancer as really a women's issue in the US, but that's really not the case. Oropharyngeal cancer caused by HPV has surpassed cervical cancer as far as the rates of cancer, and certainly as regarding mortality and morbidity. And so when we look at oropharyngeal cases overall, not all of them are related to HPV, but as we've had more effective tobacco control programs, about 60 to 70% of oropharyngeal cancers in the US are attributable to HPV. It's important to note that there is a sex difference in oropharyngeal cancer. Men are 5 times more likely to develop oropharyngeal cancer than women. The reasons for this are not completely understood. It's thought that women are first exposed to HPV through cervical vaginal contact, and that leads to antibody production that helps to prevent later acquisition of oral HPV strains, but that's somewhat speculation at this point. So HIV infection increases the risk of HPV-related malignancy. So pooling estimates around the world, it seems that living with HIV increases the risk of cervical cancer about 6-fold. For anal cancer, it's much higher. It's about 19 times higher on average. However, this is a little bit difficult to tease out because many in the US, most people with HIV have acquired, or men who've acquired HIV through sex with other men. And so they are at much higher risk, even without HIV, for acquiring or developing anal cancer. So the high rates of anal cancer we see in people with HIV are a combination both of sexual risk factors in men who have sex with men, as well as the immune suppression that drives HPV cancers in general. It's thought that the risk of oropharyngeal cancer among people with HIV is still about 2 to 3-fold higher than people without HIV. And so there are a number of other risk factors for HPV-related cancer. Certainly having larger numbers of lifetime sex partners increases the exposure to HPV and the exposure to a broader array of HPV types that can cause cancer. One really powerful risk factor for people with HIV is a prior history of low CD4 nadirs or a prior history of AIDS. And so it's that period of more severe immune suppression with CD4s less than 200 that seem to be the strongest risk factor for developing anal cancer among people with HIV. And certainly smoking. People with HIV in the US tend to use tobacco at a higher rate than people without HIV. And so that has a negative consequence for HPV-related cancers as well. All right, so this is an important graph. Take a few moments to walk you through this. So each of these rectangles is a different population of men or women, and apologies for using such binary terms. But among people assigned male sex at birth, those that have sex with men have the highest rates of anal cancer. So in red, you can see those living with HIV. And among those men who have sex with men living with HIV, there's a really strong relationship between the risk of the anal cancer and the person's age. So those over 60 years of age living with HIV have the highest risk with lower risk with lower age. And we'll talk about how we use this to determine who's eligible for screening in just a moment. When we look at other men who have sex with men without HIV, other men that don't have a history of sex with other men, among those that are living with HIV, there's still a very appreciable rate of cancer, again, a relationship with age. And if we look at non-MSM without HIV, very, very low rates of anal cancer. Similarly, for women living with HIV, those women over age 45 have the highest risk of anal cancer, with lower risk for younger women living with HIV. And something that we haven't really spent a lot of time investigating are women without HIV that have had other HPV-related conditions, such as vulvar cancer or vaginal precancer. Those women certainly are at higher risk for developing anal cancer, a second HPV-related cancer. And then other populations to think about are those that have had solid organ transplants, other conditions that are treated with immune suppression, such as ulcerative colitis and other things. But that longer duration of immune suppression really seems to ramp up the risk of developing anal cancer. So how do we put all of these rates into context? So the historic rate of cervical cancer prior to a widespread screening program, and certainly prior to vaccination, was about 25 per 100,000 patient years. So you can see in each of these groups, there are definitely populations that have rates of anal cancer much higher than the rate of cervical cancer prior to widespread screening. And our current cervical cancer rate with HPV vaccination with active screening programs is much lower. So one recommendation that's come out is to really have a cutoff and think about anal cancer screening for populations that have a 10-fold increased risk of invasive anal cancer. I'll say in advance, a lot of this needs to be really we need to have really more better cost effectiveness data to show that it makes sense economically that to consider screening these populations. But you can see that many groups would fall into these groups that you would consider for anal cancer screening. Okay, and so to put some of these cancers in perspective, here are some other rates of common cancers in the US. So you can see the very high rates of breast and prostate cancer, colorectal cancer, rate of about 40 per 100,000 patient years. And so we're talking about rates of cancer that are really that high or higher in certain populations of people living with HIV. And so for women with HIV in general, about 20 per 100,000 person years. But again, women that are older, over age 45, for example, really have increased rates of anal cancer. So we'll talk about screening tests in just a moment, but basically all of the anal cancer screening, the benefit all stems around high resolution anoscopy. This is the procedure where you diagnose somebody with HISIL. It's the procedure that guides treatment of HISIL or precancers to prevent anal cancer. So it's very analogous to cervical colposcopy. This is a plastic anoscope inserted into the anus. You use that to introduce acetic acid, which reacts with the skin to make areas of HPV damage show up. We also use Lugol's iodine. And so healthy areas of the epithelium take up the Lugol's iodine and stain like a chocolate brown. And those areas of HPV damage you can see here tend to take it up poorly and appear more yellow. And so these are areas that we would biopsy to look at to understand if there's precancer present, and then the areas that we go back and treat. So here's another example where we see the area of aceto whitening at the top there. And then later we can go back with a procedure to ablate this. This is easily done in the office and well tolerated. The vast majority of people can do this just without any kind of sedation or anxiolytic. It's this area, it's this treatment of the premalignant lesions that we think reduce the risk of invasive anal cancer. So one of the key limitation, we'll come back to this in a moment, is really there's not very many people trained in this, and then the quality of training can vary. The kind of persistence of doing endoscopy and doing it for years and really focusing on quality is also can be challenging. Generally, the International Anal Neoplasia Society offers the best, most comprehensive training, and they do have a virtual HRA course that really makes it a lot easier for clinicians to get started in learning high-resolution anoscopy. And the other point of looking at high-resolution anoscopy is to diagnose cancers if they've happened. Here's an example of a cancer that was diagnosed in one of our clinical studies here. This sort of deep ulcer, you can feel this on digital rectal exam. It's very firm, can be very painful in some cases. These really marked abnormal blood vessels that are seen. Here's an example of that you might notice on a digital rectal exam. This is perianal high-grade squamous intraepithelial lesions or precancer. So it's kind of dark, can be raised, hyperpigmented, can be slightly rough. And so this would be an area that we would biopsy and potentially treat to prevent the development of invasive cancer. So what we're talking about, why the evidence that we have to support this concept of finding people with the anal cancer precursors and then treating them to prevent the development of cancer is based on the ANCHOR study. So this screened about 10,000 people living with HIV with high-resolution anoscopy, also did cytology and stored tests for HPV, but basically just went straight to anoscopy and randomized about 4,400 people with anal cancer, anal precancer, and put them into two groups. One was a treatment strategy where the areas of precancer were treated. They were seen back 6 months later, biopsies again. If there was still treatment or still precancer, they were treated again. And that went on over the years for some individuals. For active monitoring, they were diagnosed with HISIL at the beginning of the precancer, and then watched closely every 6 months and underwent biopsies yearly to just monitor the HISIL and to look for invasive cancer. I will note that if people had suspected cancer or they were imminently thought to develop cancer, they were screened more closely to catch the cancer as early as possible. And so what was found that after a median follow-up of 2 years, some people have been followed for 7 years and 8 years in some cases, there were 30 cancers overall, 21 in the group that was just monitored, 9 in the group that received treatment, with an overall, I think it was a 57% reduction in the risk of anal cancer. One thing I want to draw your attention to is just the rates of cancer among these people with precancer. So those that were actively monitored, it was 4 per 100,000 patient year, or 0.4% per year. Really very, very high cancer rates. And even those that underwent treatment, it was a reduction in the rate of anal cancer, but still a very high rate of cancer, suggesting that we really need to have better therapies for the anal cancer precursors. Again, a 57% reduction, and you can see the confidence interval associated with that. Okay, and then this just shows it over time, and you can see the the number of people in follow-up at all of these times. I mean, really a robust, well-powered study. It seems to me like the risk of the proportional hazard seemed pretty constant over time between the two groups. So some controversies that still exist is we need improved anal precancer treatments. Ideally, we're focused really on ablation now, but are there other adjunctive therapies that could improve our responses over time? Are there therapeutic HPV immunotherapeutics or therapeutic vaccines that might improve our ability to cure anal precancer? And I think practically it's the widespread access to quality HRA that really makes a difference. We need larger scale training programs. We need improved, better data on what's the best screening algorithm in specific populations. And it would be great if we had a biomarker that could really understand among those with precancer who's really at risk for developing cancer and who is perhaps can be treated more conservatively. And then can we extend these results from people with HIV to other groups with immune suppression? I would suggest probably we could. We could probably use just the clearance rates of anal HSIL to kind of bridge to these other populations. It seems unlikely that we would have additional clinical trials in other groups at risk for anal cancer. So I'm just going to spend a couple moments talking about some of the guidelines. So basically, the way HPV cancer screening works is there first is a screening test. There can be a triage test. So among those who screen positive, who are test positive on the screening test, you can triage to say which among that group, what subgroup would move on to the diagnostic HRA evaluation. So the screening tests are pretty limited. We have cytology, HPV. In some cases, you can do both, which is called co-testing. And then those same tests can be used for triage. And all of this is really to determine who should go to a diagnostic evaluation with high-resolution anoscopy. So on the right, not so important, this is from the EANS guidelines. So this is the society that's comprised of people who do this for a living. And so they have specific recommendations. If you start with cytology, what could be a triage test? If you start with HPV, what could be a triage test, and so forth. The CDC opportunistic infection guidelines are similar, but perhaps a little more restrictive in what they recommend as far as the screening evaluation. So they recommend, first of all, screening men who have sex with men and transgender women with HIV age 35 or older. And then all other groups of people living with HIV, including women living with HIV at age 45. And this is just based on the rates of invasive anal cancer. And then they take a practical approach. Is HRA available? And so if it's not available, it's basically the digital rectal exam and then referring to evaluation, people who have abnormalities. If you do have access to HRA, then there is the algorithm, again, with DARE, but then moving on to the screening tests. And so they recommend cytology, alone or with HPV co-testing. And then I won't go into the details of this, but there's a referral to anoscopy depending on those results. So just a reminder about digital anorectal exams, that even if we don't prevent invasive anal cancer, if we can find it earlier, people have better survival outcomes. If you find it very early when it's superficially invasive, you can treat it with surgery alone and get very good outcomes. But even if that's not possible, if you can diagnose and treat when it's localized or regional, you have much better outcomes than if you have distant or metastatic spread. So what do we need to do now as far as anal cancer screening? We need to really build HRA capacity. So who can do this? Variety of people around the country do this and are very talented, but certainly gynecologists have the training in cervical colposcopy. So I think it's the easiest lift for them to take on. learning anoscopy. Many APPs, I work with talented nurse practitioners, PAs that do a great job with this procedure. This was invented. The first person who wrote the seminal article, Naomi J, is a nurse practitioner. Certainly family medicine who have GYN experience are quite capable of this. A lot of who you see are internal medicine and HIV medicine doctors. Some surgeons do this. This isn't maybe totally in their comfort zone, but if you, anal cancer screening programs should have a surgical collaborator because there's a lot of other issues that are developed, and sometimes you do need a surgical approach. Based on HRA capacity, you really have to decide locally how much, what are the resources you have, how many people can be seen for HRA and treatment, and then you can use that to determine what subgroups or what screening strategies and management strategies to either send those that are at the very highest risk or to send people for HRA that have a much more broader risk. And then also it's very important to have treatment capacity built into HRA capacity. So the people that do HRA really need to be able to perform the ablative treatment to really make it easier and have less referrals made. So one place that they go to for their screening and treatment. Okay, just a few minutes on HPV vaccination. So there's a lot of controversy about vaccinating people up to age 45. And so what this is really based on, this recommendation, was a specific study that looked at people in that age range that really had no history of HPV disease and were kind of, I'll say, lightly exposed to HPV. And they did show vaccine efficacy, prevention of infection and disease regarding this. And this has been used to extend to other populations. So it's really, this does not really apply to, these data don't really apply to most people living with HIV who have had more extensive sexual histories and have had more exposure to HPV and more infection with HPV. So the current ACIP guidelines is to vaccinate with 2 doses early on, and then if you don't start vaccination by age 15, to use 3 doses. I'm just putting this up there to make all of you HPV vaccine champions. Just getting that first dose of HPV at an early age is really critical to the vaccine efficacy. Let's go ahead and skip that. So that the vaccination of early age is where I think we need to focus as a country. I think there's some groups at older ages that could benefit from HPV vaccination, but really the public health impact is really putting the resources into getting younger individuals vaccinated. Some of the data about anal cancer prevention, this was data from a long time ago that the vaccinated had lower rates of either HPV infection or dysplasia related to HPV. There was a study that then took those individuals and followed them, a subset of them, longer term to look at HPV disease. So those who had originally gotten placebo got vaccination at a later time point, and then compared to the group that had vaccination at the beginning. But over the longer duration of follow-up for those who had been originally assigned to vaccine, there were no cases of vaccine type related warts, dysplasia, or cancer that was seen, suggesting some really long-term benefit. And then there are some population level data that shows that the rates of anal cancer among those who had been vaccinated younger than age 17, this is out of Denmark, really have little to no cases of anal cancer, as opposed to groups that have been vaccinated at a later age or who had never been vaccinated. Oropharyngeal cancer, there's currently I think it's like a provisional indication from the FDA for the vaccine to prevent oropharyngeal cancer. And it's based on a couple different things. One of them was the Costa Rican bivalent study that they did not look at HPV, oral HPV at baseline or in follow-up, but when people were leaving the study after 4 years, they did get oral rinses and showed that the prevalence of oral HPV at the exit from the study was markedly reduced in those that had been vaccinated. And a study that we did in the ACTG that took a much broader age range of people. We did find that the persistent HPV vaccination was lower in those that had been vaccinated, but the confidence interval was pretty much as wide as you can get. And so for efficacy, so this really is needs to be confirmed in other studies. So currently there's 2 studies that are ongoing with the 9-valent vaccine, one sponsored by Merck for men without HIV, and then a study that we're doing sponsored by the National Cancer Institute being conducted in Brazil, Mexico, and Puerto Rico of men with HIV age 20 to 50, where we're trying to show that in this age group that vaccinating people will prevent oropharyngeal infection with HPV that we're using as a surrogate for prevention of oropharyngeal cancer, a cancer that does not have an accepted screening modality at this point. And really the only choice to reduce oropharyngeal cancer at this point is to prevent HPV. So just to mention that there are single dose data with single dose HPV vaccine and young women without HIV that supports a single dose being effective, at least over the medium term. There are some vaccines that are looking at even broader, moving beyond 9 to say 12 or 13 types. And then there are other more therapeutic HPV vaccines that are under investigation that will hopefully give us additional options for treating precancers related to HPV. So HPV is extremely common. We know that people with HIV have higher rates of cervical, anal, and oropharyngeal cancer compared to the general population. These oropharyngeal cancer rates are rising. Anal and cervical cancer are preventable, and there are screening guidelines that exist. I recognize that access to HRA remains a challenge, and basically you need to build this capacity locally. Oropharyngeal screening modalities recommendations are lacking, but there are some progress being made. And current HPV vaccines are an incredible advance, but really are effective when given prior to sexual activity, and that should be our focus. And just amazing collaborators I just want to thank that have helped with this.
Oh, fabulous, Tim. Just a great overview. We have a lot of questions. I'm going to dig right into them here, and I have a couple of them, but I'll get to the audience questions first. So Kevin wants to know, do you have comments on patient-collected anal paps and that subset of patients who prefer this? What do you think about the data on the accuracy of that compared to a provider's collection?
The only data that there are some small data on self-collected cytology. I think for HPV testing, it makes a lot of sense because people definitely, we know that a lot of people, even though it's not FDA cleared, a lot of clinics have implemented self-swabbing for gonorrhea, chlamydia testing. That's been very acceptable. So I do think that that is a great option, especially for HPV. I'm not aware of tremendous data for cytology. I will say that there's good reason to think that many people might do a more vigorous swab on themselves than kind of cautious providers are doing on people. So it is something that would merit investigation and certainly help with implementation.
So when you mention HPV screening in that fashion, if let's say you implement that strategy, you get a swab, you send it off for HPV and it's negative, does that preclude you from going back and doing a cytology or a pap smear?
If it's HPV negative, I think people feel pretty comfortable with a good sample of the really negative predictive values. And the reason is because pretty much all the assays, not the old Digene assay, but all the newer PCR-based assays, all have an internal control that can tell you, yes, this is an adequate sample, therefore I can trust it. What's really exciting about HPV data is that there's a lot of information in some of the newer tests. I mean, not many labs have implemented like BD on Clarity, for example, that has like 6 different HPV test results. And so there's really exciting work that's we and others are doing to look at the array of HPV types, the amount of HPV that's present to really help stratify the risk of precancer. So I think there's going to be a lot of exciting developments and the accuracy of HPV-based screening. I will point out that the CDC OI guidelines really focus on cytology, and then with HPV as an add-on.
Yeah, seems like cervical cancer is definitely going that way.
Yeah.
So the question, just out of curiosity, again from Kevin, oral pharyngeal cancer, is there a way to maybe just screen for HPV there? And I'm not sure exactly what area, whether it be the buccal mucosa or throat, but is there any data that you're aware of or any studies looking at screening for oral cancer?
Yeah, I think one of the I think it's not so much related to HPV collection that people are focused on right now. There's two things. One is antibodies, certain antibodies that seem to be kind of specific to oropharyngeal HPV infection, specifically HPV 16. So about 90% of HPV oropharyngeal cancer is caused by HPV 16. So there's certain antibodies to HPV E6, for example, that can be used to screen large numbers of people pretty inexpensively with serology, and then taking those that are positive and then doing a more expensive test. And the more expensive test is circulating HPV DNA that is used as a biomarker to assess response to treatment of oropharyngeal cancer. So that's kind of the strategy that's emerging. But I don't know of any localities that are implementing this on a widespread basis.
Yeah, maybe it's an emerging area. John wants to know of the evidence that HIV-related immune suppression is causal in the cancer. And clearly, epidemiologically, you showed very nicely up to almost 40-fold risk. Do you think that's from an immunosuppressed state that maybe allowed the HPV to get a better foothold before, say, for example, antiretroviral therapy was started? What are your thoughts on the pathogenesis there?
Yeah, I mean, I find it very compelling that people who are diagnosed early in HIV that never had immune suppression, some epidemiologic studies suggest that their risk of anal cancer is basically the same as people without HIV. And then this was confirmed in the Anchor study that one of the strongest risk factors was having a history of lower CD4 counts for the development of anal cancer. We know that it's the T cell response that is responsible for clearing infected HPV cells. And, that's obviously compromised with HIV. So there's lines of evidence, but, I guess there's no way to know for sure, but all of the data points the same way.
Yeah, just thinking out loud with you here that it seems like for other viral infections, especially CMV, but maybe to a lesser degree HSV, that it's a virus, it's HIV at high levels that really causes the immune suppression. When you treat the HIV and the viral load drops precipitously, though the risk of those viral infections or expression of the viral infections goes down dramatically. So I wonder if just the treatment actually takes care of that, but maybe the longer term exposure to high level HIV is really an issue that may get the process started. A related question, let's say you have someone who got a full series 2 shots of HPV vaccination when they were 11 years old, and then they acquire HIV. Do we have any long-term data? Is their risk also pretty low or similar to the non-HPV related folks?
It's a great question. I don't think we have any data. I mean, for me, if I were to, see someone clinically, I would probably just revaccinate them with the 9-valent series because, it's a small population and the vaccine is totally safe. I think globally it's a huge issue, right? As people are rolling down even a single dose HPV screening program, what does that mean for that individual's long-term risk? So I think there are some efforts underway to study that, and mainly in sub-Saharan Africa. It'll be very interesting. Ideally, prevention of HPV will help to reduce the risk of HIV. Obviously, won't in and of itself, but hopefully will be at least help to lower the risk of HIV infection as well.
Yeah, and it begs the question, like when I look at the data you presented on the protective effects of even the four-valent vaccine, it made me wonder, um, you're not, you didn't talk much about breakthrough um, cancer of other um, serotypes that were not included in the vaccine. And I'm wondering whether there's some more pan HPV protection that's given even from the four-valent vaccine. What are your thoughts on that?
Yeah, I mean, there was some data with the bivalent that just so type 16 and 18 cause about 70% of HPV cancers. And I will say about 5% of cancers globally are caused by HPV. So 16 and 18 cause 70% of cancers. So there was some early evidence from the bivalent. There did seem to be some cross protection with other sort of related types. I don't think, I think, in the US and other areas of more resources, everyone moved on to the 9-valent. The bivalent is just not available.
Right.
But so I think, yeah, there is some evidence of cross protection, but really the number of cancers that cause any kind of sizable number of HPV types that cause any sizable numbers of cancers are in the 9-valent. And if they expand to 12-valent, that will basically take care of it.
And Sanjeeva asked a similar question about the non-valent HPV vaccine and that it's mostly in high-income countries. And um, do you sense that that's going to become available more globally over time?
I mean, I certainly hope so. I mean, there was a shortage of the vaccine for a while. So I think that slowed some of the efforts to distribute it more globally. But, it's something I'm strongly supportive and hopefully everybody is as well. I mean, that if you're taking the time to put the injection in the arm, you might as well use the best vaccine.
Yeah.
And so cost issues, it is more complicated to make, so therefore more expensive. But especially if you're using a single dose, that would really give you the broadest protection.
Yeah. Lisa wants to know about recommendations for anal paps for women, especially those over 45.
Well, I do think that is an especially important thing to remember for later in the day, but it's based on anal cancer rates. And so the recommendation from the OI guidelines, CDC OI guidelines, the cutoff they use is age 45. So 45 for women living with HIV, age 45 for men without a history of sex with other men with HIV, and then for men who have sex with men with HIV, age 35 to start screening.
Yeah. I think these are all really vitally important things that you covered it so well. What do you think about the single injection? I'm working on a project now in Guatemala and with young people attending schools and giving them a single shot because it's easier to track. They got it and then have to worry about tracking them for their second injection. I found the data that I've looked at pretty compelling for at least a pretty good coverage with even just a single shot.
Yeah, I think it's a tremendous advance. I will say, if you go to an HPV conference, you can definitely get arguments started by raising this question. I mean, I think it's all about choices. I mean, the 2-dose series has incredibly long follow-up. We see the impact on a population level. It works incredibly well. So, but if you're an area, a country that does not have ready access and you've not had successful vaccine screening programs, you can really, I think it'd be much more effective to vaccinate 1 million people with a single dose than to vaccinate 500,000 with 2 doses. And so this opens the possibility of not just vaccinating girls, but also vaccinating boys.
Yeah.
And I think it is imperative that we have long-term cohort studies to look for these breakthrough infections that really can show that this vaccine, a single dose, will work not just for a couple of years, 3 years, but 5, 10, 15 years.
And just finishing up here, last question coming in about an anecdotal story. Had a patient with HIV and genital warts, got the HPV vaccine, and the warts disappeared. What do you know about vaccines and the treatment of genital warts?
So yeah, the clinical trial data that I know of doesn't really support this therapeutic effect. We looked in the ACTG study where we had people with anal HSIL, and we looked at the outcomes in those that were randomized to vaccine versus placebo, and there was no difference. We had a study in South Africa where we took women with cervical HSIL, randomized them to vaccine or placebo, and we saw no differences in the cervical HSIL outcomes. I think there is some sense with recurrent respiratory papillomatosis, a very specific condition of HPV condition in the oropharynx for those genetically predisposed, that perhaps that vaccine does sort of help that long term. I mean, I think there's nothing to recommend it, but the vaccine's
Right.
safe, and that there's other reasons you might as well vaccinate.
Yeah, and sometimes warts just go away, but
Yeah.
so we need so it's good that there are some data on that. Well,
Yeah.
thank you for a wonderful
Okay.
review of a really complex topic for which there's a lot of advance lately, and I think we can all use this in practice.
Thank
Thanks,
you.
Tim.